So as people are entering, I'd just like to introduce myself. I'm Ivy Bourgeault. I'm the lead of the Canadian Health Workforce Network, and I'm very pleased to have you join us for the last webinar of our 2011 season, which happens to be the WHO International Year of the Health and Social Care Workforce. So I just wanted to start first by acknowledging territory where we are located here. The Canadian Health Workforce Network is here in Ottawa, the unceded territory of the Algonquin Anishinaabe people. And so we pay respect and are very pleased to be able to undertake the work, live, work, and play in this territory. So the topic for our webinar today is integrated primary care workforce planning in the City of Toronto, looking at inputs, processes, outputs, and impact. And this is very much a partnership between Ontario Health Toronto Region and the Canadian Health Workforce Network. And so this is work that we undertook in 2017. The health analytics team at Ontario Health Toronto, what used to be the Toronto Central Inn, partnered with us at the Canadian Health Workforce Network to co-develop and operationalize a fit-for-purpose toolkit to support integrated primary care workforce planning in the Toronto region. So just to give you a sense of what the agenda will look like today, we have divided the webinar into two parts. First, we will present an overview of the primary care health workforce planning work that has been done to date. And following the presentation, there will be an opportunity to ask questions of those panelists. Then we will have a second panel discussion that will explore issues related to the impact and implementation of the project. And there will be another opportunity to ask questions of the experts on the panel before the session closes. So I'm going to pass now to Cynthia.
Thanks a lot, Ivy, and good afternoon, everyone. This project stemmed from a need to address disparities in access to integrated primary care across the City of Toronto. In conversations with stakeholders, we heard that equity was a top of mind concern. Everyone wants to allocate resources to those who need them most, but it's not always clear how to make this happen. Ontario Health Toronto recognized that the region, Ontario Health teams, and all our other stakeholders in the system would need support to make evidence-based decisions, particularly with regards to deployment of the workforce and other health system resources. Ontario Health Toronto partnered with the City of Toronto to plan for rapid population growth in the city and its impact on the health system. There was a need for a detailed primary care capacity plan that identified population needs, anticipated growth, and existing assets in order to inform investment planning throughout the city. Next slide, please. The project unfolded in two phases. In phase one, which took place between 2017 and 18, we conducted a targeted review and assessment of existing planning models and an environmental scan and assessment of available data sources. These activities informed the development of a health workforce planning toolkit that included a fit-for-purpose quantitative planning model. In phase two, which started in 2019 and is still in progress, we are implementing the process and are almost finished operationalizing the first cycle of planning. We have mobilized data to populate the quantitative model, and we're using the tools in the toolkit to guide the process and produce various outputs that will be helpful to decision makers. Next slide, please. Taking the region's core needs and key challenges into account was an important component for this project. We wanted any planning done to be population needs-based and evidence-informed. We wanted it to be integrated and multi-professional, including all the providers and services involved in the delivery of primary care. We needed to be able to look at the population needs and workforce capacity at the neighborhood and sub-region level and whole city level. And rather than long-term projections and forecasts, we wanted to work with short planning horizons more in line with regional decision-making timelines. The planning approach and toolkit also needed to address certain challenges specific to Toronto, such as patient mobility, population growth, and anticipated physician retirement. Next slide, please. Our consultations at the beginning of the operationalization phase resulted in a statement of purpose that you see here, and which has guided our activities. Our goal was to build a body of evidence around the current and projected future states of population health needs and primary care service provision at neighborhood level within the city. I'll pass it on to Carolyn.
Carolyn, you're on mute.
I am on mute. Apologies for that. So our workforce planning process includes horizon scanning, scenario generation, and quantitative workforce modeling. These activities inform policy analysis and decision-making. The whole process is iterative and prioritizes a 3 to 5 year planning horizon. This is in line with regional decision-making timelines and allows for regular course correction and adjustment of policies to promote more stable alignment of workforce supply and population health needs. The process is also interactive, and engagement with local stakeholders in Ontario Health Toronto's network of partners features prominently. A series of environmental scanning tools are included in the toolkit, and the quantitative workforce planning model that we developed in phase 1 is also embedded in the process.
The quantitative workforce planning model is composed of a series of modules which both stand alone and interact with other components of the model. The population health profiles module describes population characteristics that impact the need for primary care. These variables allow us to consider the impact of changing population characteristics on service requirements and to address the question, if population characteristics change, how will service requirements change? Failure to consider unmet healthcare needs risks perpetuating current inequities. And so the model includes a module that captures information related to unmet need. The population growth module captures neighborhood level population projections, allowing us to predict service requirements for future populations. We're able to focus on neighborhoods with significant anticipated population growth due to new vertical development. Recognizing that not everyone receives all their care in one place, the spatial patterns of utilization module estimates the number of visits required by residents and non-residents of each neighborhood and adjusts service requirements accordingly. These adjustments are based on current utilization patterns and are considered to be a starting point for analysis of scenarios related to care-seeking behavior. The data for this module came from ICES, and the analysis of the module was done at ICES. The service requirements module draws from other modules to estimate the primary care service requirements of the population receiving care in a specific geographic region. The workforce profiles and service capacity modules describe the primary care workforce and estimate the capacity of the workforce to provide service in current and future years. These data originate from ICES, and the analysis was done at the Ontario Community Health Profiles Partnership. After an initial assessment of alignment, an optional allocation step is included in the model to allow services to be shifted between providers with overlapping scopes of practice or to virtual care to optimize alignment and minimize the gap between workforce requirements and workforce supply.
Okay, great. Thank you, Sarah. So we've created a number of outputs from the planning process. The quantitative model has a number of modules that produce intelligence about the population and the workforce. Each module has a spreadsheet that captures all the relevant information, such as adjustments and scenario analyses. Using data from the modules, have generated tables, charts, maps to synthesize and summarize emerging findings. For each neighborhood, we have produced a series of static dashboards that bring together information about the population, the workforce, and the alignment of the two. A variety of descriptive outputs at the whole city level, as well as some gender-based analyses, are also available. We have built 2 interactive dashboards and are planning to make these available to stakeholders to help them explore different retirement and population growth scenarios. Great, next slide. Okay, so using the data sets that we have assembled for the planning model, we have conducted a series of analyses intended to help stakeholders and decision makers understand more about the primary care providers in the region. There are significant gender differences in the distribution of primary care physicians by age group. Most of the younger physicians are women, as we can see on the orange bars, while most physicians in older age groups are men, as we can see on the blue bars. Because workload and practice patterns vary across physician age and gender, understanding the structure of the workforce in this way allows us to be more accurate in our estimate of physician service capacity. Okay, so one of the key challenges that we focused on was population growth resulting from future city developments. This map shows that there's variable population growth projected across the city over the next 10 years, with the highest rates seen in the dark blue. So population growth ranges from 0% in some neighborhoods, so that's in the yellow shading, while some neighborhoods go up to 141%, as we can see in the waterfront communities. So we have a notable concentration down in our downtown core. Identifying areas of anticipated growth will allow for us to plan to ensure that primary care resources are available to new residents of these growing neighborhoods. Absence of such planning may have negative impacts on the healthcare system, such as increased use of emergency departments or longer wait times for care. Great. So we know that many patients from all over Ontario come to Toronto to seek care, and we've been able to quantify this flow, as you can see on the 2 maps. 1/4 of all primary care visits, or more than 2.4 million visits in 2016, are provided to patients who live outside of Toronto, so outside of the borders that we see on the maps. We've been able to describe the distribution of incoming demand across each neighborhood, as well as look at how many patients seek care outside of the city. The map on the left shows patients living on the edge of the city are more likely to receive care outside of Toronto neighborhoods. So that's in that dark blue that we can see. This makes sense and highlights the limitations of neighborhood geographies when it comes to planning. We also now know how much care patients access in their own neighborhoods. So some neighborhoods deliver a lot of primary care to local residents, while in other neighborhoods, residents will go elsewhere, or outside of their neighborhood for care. The pink map on the right helps to visualize these patterns of access and care. This exercise allows us to identify neighborhoods that we consider as care hubs, or destinations where patients from across the city that access a high volume of care. Adjusting for patient mobility helps us to understand how patients seek care and improves the accuracy of our neighborhood level estimates of service requirements. Okay. So in each neighborhood, our estimates of service requirements account for the care needs generated by the resident population, patients from other neighborhoods, and patients from outside the city. Our baseline estimates of service capacity account for volume of care expected to be delivered by both comprehensive primary care physicians and non-comprehensive physicians, such as those working in walk-in clinics. Once these estimates were produced, we were able to assess the alignment between service requirements and service capacity of each neighborhood. Our approach uses a comprehensive synthesis of data on the population and the workforce to identify the factors that contribute to the observed alignment. We can then engage with local stakeholders to validate our observations and develop plans and solutions for future issues. As one would expect, there's significant neighborhood level variability in the local workforce capacity to meet the primary care needs of residents and from patients from outside the neighborhood. This variability is shown on the map to the left of the slide. The neighborhoods in in blue to green shades have higher capacity, while those in the yellow and brown shades display significant service gaps. We can also identify neighborhoods with anticipated future deficits in primary care. As the graph shows on the right-hand side, In St. Jamestown, so one of our neighborhoods in, I guess, downtown Toronto, service requirements are projected to increase over time, while service capacity is also projected to decrease. This means that within this neighborhood, by 2021, service requirements exceed the service capacity that is not at risk of loss due to retirement, which is leaving a widening primary care deficit. Additional primary care resources could be directed to this neighborhood to attenuate the deficit and minimize the gap.
Great, thank you, Nathalie. So the first of our static dashboards is a neighborhood profile. At the top of this snapshot, a graph and accompanying infographic reflect the alignment between service requirements and service capacity within each neighborhood from 2026 through 2016 through 2026. This description of alignment is complemented by a synthesis of key findings from each of the health workforce planning modules. From the population health profiles module, the profile features the age distribution of residents and the prevalence of a number of key health conditions, including asthma, hypertension, COPD, diabetes, the population with 2 or more chronic conditions, and the population with 4 or more chronic conditions. The module also features the estimated population growth for each neighborhood, an estimate of yearly incoming and outgoing primary care visits based on the baseline spatial patterns of utilization, and the neighborhood's Ontario Marginalization Index scores. Finally, indicators of unmet need for primary care, including attachment rates and ambulatory care sensitive condition hospitalization, and the prevalence of low urgency emergency department visits, round out this neighborhood profile. In this illustrative example of Briar Hill, Belgravia, we see that while the neighborhood displays a surplus of capacity in our base year, by the end of our planning horizon, it appears to have a significant deficit in workforce capacity. This profile allows us to note that the neighborhood is expected to see very little population growth, which means that the emerging gap can likely be attributed to the significant decline in service capacity and growth in other neighborhoods that's increasing incoming demand. We have also created 2 additional static dashboards in order to provide stakeholders with a more in-depth description of the factors that are shaping our neighborhood level estimates of service requirement and service capacity. The service requirement dashboard breaks down the neighborhood service requirement estimate into 3 key components: the number of visits expected to be accessed within the neighborhood based on population need, baseline spatial patterns of utilization, and estimated population growth; the number of visits expected to be accessed by residents of other City of Toronto neighborhoods in this particular neighborhood based on their population need, baseline spatial patterns of utilization, and estimated population growth; and finally, the number of visits expected to be utilized by non-city residents in the neighborhood based on baseline spatial patterns of utilization. As you can see in this example of the Bay Street corridor, in some neighborhoods, it is not resident visits, but rather non-resident and non-city visits that are driving service requirements and highlighting the importance of considering patient mobility and exploring alternative utilization scenarios. Similarly, the service capacity dashboard reflects the contribution of 3 key sources of physician service capacity to each neighborhood's service capacity estimate: the estimated number of visits provided by comprehensive primary care physicians who are not expected to retire, the estimated number of visits provided by comprehensive primary care physicians who are considered to be at risk of retirement, and the estimated number of visits provided by non-comprehensive care physicians. This breakdown is critical to workforce planning, given that in the annex, for example, over 50% of service capacity generated by comprehensive primary care physicians is considered to be at risk of loss due to retirement by 2023. This dashboard also provides a summary of the primary care service capacity available within the neighborhood across the 13 other healthcare professions.
We've also designed an interactive population growth dashboard, which is a tool that can be used to explore 84 different scenarios that are relevant to primary care planning and decision-making. Users start by choosing a level of geography and a population growth scenario. In the Mount Pleasant West neighborhood, we see population growth of 10.27% per year, quite significant. The primary care services that patients will need are shown in the upper right-hand panel, and the alignment is displayed in the lowermost panel. This scenario results in a significant gap between service requirements and service capacity, which grows over time. We can see what happens to alignment if population characteristics change. If we want to see the impact of aging and mental health visits, we can add these adjustments. When we do that, an adjusted curve is displayed and the panel tells us how much change to expect. In this case, the number of visits increases by 1.14%. And we also see a larger gap between service requirements and service capacity. Then we can look at workforce scenarios that might change the gap. We can explore the plus 10% workforce scenario, which results in a reduced gap between service requirements and service capacity, or we can explore plus 5% or minus 5% scenarios. Now we're going to talk about some of the key challenges and facilitators for this project. Multiple challenges were encountered during this process, and we're happy to enumerate these and share some of the strategies that we adopted to address these challenges. We've had to adapt to an evolving landscape of health system transformation and to consider how to align our outputs to optimize their relevance. In some cases, neighborhood level planning remains aspirational, and we're reliant on local consultation and descriptive input to generate results that are relevant. When we defined primary care, we consulted widely and eventually adopted a holistic definition that reflects the interprofessional nature of integrated comprehensive primary care. But we also recognize that primary care is sometimes delivered outside of comprehensive primary care relationships, and we had to develop a process to account for this. Availability and accessibility of data to regional level planners is a major barrier to evidence-informed decision-making. Data on physicians and the allied health professions that are high quality, granular, comprehensive, and timely have been quite difficult to find. We adjusted our methodology to accommodate aggregate level data and third-party analysis, but data lags and limited longitudinal information constrain the extrapolation we can do, and in some cases may undermine the accuracy of our projections. Lack of standardization and concerns about data quality limit our ability to do true team-based planning. And delays in access to data extended the timelines for the project considerably. We continue to work on multiple fronts toward improving access to health workforce data. Mobility of patients and service providers continues to be a challenge to neighborhood level planning. We have characterized patient flows around the city and incorporated adjustments for spatial patterns of utilization into our estimates. But care-seeking patterns are dynamic, and they influence and are in turn influenced by the primary care landscape. And so they will continue to be an ongoing challenge to planners. There are limited data available to estimate unmet need. Starting with available quantitative indicators and incorporating qualitative insights to develop estimates that can be used in modeling is necessary. Finally, the changing landscape of primary care planning has resulted from the pandemic, and we have had to incorporate considerations related to virtual care, early retirements, and the changing role of pharmacists into our processes. We've done this by using inclusive data synthesis and scenario analysis, but the importance of an iterative planning process to be able to address emerging issues in planning cannot be overstated. In the realm of health workforce planning, broad consultation and engagement, and the focus on building partnerships and capacity are what has made this project unique and successful. At every stage, we've consulted with stakeholders to find out what is important to them. We listened to their priorities and planning challenges and designed a fit-for-purpose approach. It's one thing to produce quantitative estimates of service requirements and workforce capacity, but it is engagement with local stakeholders that will validate those estimates and allow adjustments to be applied to make the outputs relevant and useful. Many planning efforts by consultants produce black box models that lack transparency and are essentially single use because local planning capacity is limited. The strong pre-existing relationships between the Toronto region and their stakeholders and the commitment of the health analytics team to best practice and best data were an incredibly important foundation for building planning capacity as part of this project. Also, we couldn't have done it without help from one of our key partners, the Ontario Community Health Profiles Partnership. The manager of this partnership, Anne-Marie Tynan, is now going to provide an overview of the support that OCHPP provided to this partnership and project.
Thanks very much, Carolyn. Sarah. So I have a very short presentation, but I'm very delighted to acknowledge the Ontario Community Health Profiles Partnership, OCHPP for short, and our team's work in the provision of some of the data for this really important project, and as well as our ongoing commitment to providing some of this data on the publicly accessible OCHPP website. Before I introduce the team and their roles, I just wanted to note that our team works at the MAP Center for Urban Health Solutions, located at St. Michael's Hospital, and that St. Michael's Hospital does provide us with some core funding for our work, for which we're very grateful to that. So the next slide, please. So as you see here, OCHPP is a partnership of health and community agencies, and we work very collaboratively together. There's no top-down or board or leadership. We work very collaboratively, and before the pandemic, we were meeting annually to develop work plans and key priorities and projects. But for this particular project, the Integrated Primary Care Workforce Planning Project, many of the data were derived from ICES data sets that are available to us. We do have a key partnership with ICES, and in fact, ICES provides us with, I'd say, 99% of our health data. We had access to databases such as the ICES physician database. We used the term PracType when we were generating some of the data, to the registered persons database, postal code conversion files, and multiple geographic files that are available to us here and at ICES. We helped the team with their data creation plans. It was a very consultative process. We had lots of emails, lots of meetings, lots of consultations, multiple iterations of the outputs, and a final rigorous review of the data before we could release it to the University of Ottawa team and CHUN and Ontario Health Toronto. And we are currently working on incorporating the data sets and the modules into a dashboard on our OCHPP website. Next slide, please. So here's our team. We're a small but mighty team. We are led by Dr. Rick Glazier, who's a family physician and research scientist and is very, very well versed in population health and primary care research. So he's a perfect lead for the team. We have our medical geographer, Peter Gazdiera. We have a GIS specialist and spatial analyst, Gary Maloney. We have epidemiologist, a data analyst, and a senior research associate. That's the three titles of Dr. Mohammed Aga, located at ICES primarily, but working with our team. And we have a wonderful web developer, Nadia Minkowska, and myself. We've had a long time collaboration with Ontario Health Toronto, and it's in its various incarnations. So we're really grateful to them. for including us in many of these projects. I especially wanted to acknowledge today Mohammed and Nadia, who have been working extremely hard on the project. Mohammed generating all of the data, Nadia working on the current website, and of course, all the maps produced by Gary and Peter and Rick for all the work in between all his other work in checking all the data for small cells and releasing it. So that's our small team here at MAP at Community Health Toronto. And then the last slide, please. This is our website. This is how you can take a look at the dashboard eventually, plus all the other health indicators we provide. It's a freely accessible website, no password, you can just log in. The project's been established for well over 15 years, and we have a great expertise in small area analysis, administrative data linkages, geospatial and analytic capacity. We provide data over time trends data, and very focused on population health with through an equity-based lens. We're very grateful to have been asked to have been part of this project, and we hope we can continue to support the project as it moves forward. Thanks again for inviting me to speak today, and I'll turn it over to the next speaker.
Great, thank you so much, Anne-Marie. So heading over to the next slide. Okay, so outputs, as Marie just spoke to, they'll be available on the OCHPP website. Interactive dashboards and more detailed information about the specific communities can be requested through our team here at Ontario Health Toronto. Tools developed for the toolkit are open access, and they will soon be posted on the Canadian Health Workforce Network website. And finally, we're working on a RISE brief to provide further support around workforce planning to the Ontario Health teams. Next slide. Okay, so the approach that we've adopted to primary healthcare workforce planning will help providers learn more about who their patients are, where they come from, and where their primary care needs are. We'll help to estimate the primary care resources needed to care for patients, as well as where we can best deploy these resources. For example, we can use these data and tools to support decisions such as where we can place managed entry positions, which communities would benefit most from family health teams, and where we can direct other allied healthcare resources. As the Ontario healthcare teams mature, they'll be able to use these tools to identify and address emerging health needs while accounting for population growth, demographic shifts, provider retirement, and changing practice patterns. They'll also be able to advise strategies to transform care by testing a range of relevant scenarios.
Thanks, Nathalie. In conclusion, this project is a case study in best practice health workforce planning. Its ultimate impact remains to be seen, but we are optimistic that it responds to an urgent need for intelligence to support better health system decision making. We will use the processes, data, and outputs and collaborate with local and frontline stakeholders to validate the results. In keeping with iterative nature of planning, we will refine the model on an ongoing basis. We will update the data with 2021 census information, updated population projections from the city, and more current primary care utilization and workforce information. Evaluating the projections and operationalizing the allocation model is also a priority. The toolkit and model will be shared with other agencies doing primary care workforce planning to promote use of a common methodology and to help spread and scale this type of leading practice. Next slide, please. If you would like to learn more about this project, we encourage you to check out these 3 articles recently published in Human Resources for Health. Also, please don't hesitate to reach out to the Toronto Region Health Analytics team or to the Canadian Health Workforce Network team with requests or questions. In conclusion, next slide, we offer a big thank you to all our partners, as you've heard, who have contributed time, expertise, and data to this project. Thank you. that ends our presentation.
Thank you so much for a really, really rich presentation. I think what I'd like to do now is maybe we'll stop sharing screen for a moment and allow people to unmute themselves if they would like to ask some questions. If you could, I know some of you have introduced yourself in the chat, but please, when you ask a question, it would be great to introduce yourself. Janet, please go ahead.
Hi, Jan Hatcher-Roberts, WHO Collaborating Center for Knowledge Translation and Health Equity and School of Public Health. I'm really interested in the application of this internationally or globally. I've been working with a group in the city of Cali, Colombia, who they've done a interactive GIS very similar to this on where the services are, but not everything else. And so are you willing to reach out globally with people that might be interested in linking, or are you staying close to home?
I'm going to pass that to Carolyn maybe first.
Yeah, absolutely. So we're definitely interested in consulting with other people and seeing where this particular methodology can go. One of the key things that make it a little bit more Canadian than international is that our population needs estimates are specifically using the CHI population grouping methodology. So It's kind of a made in Canada approach that's using a made in Canada tool that was provided to us by CHI. So there would certainly need to be some adaptation for translation to other jurisdictions, but we're more than happy to have consultations with people in order to kind of share best practices and share our approach with others.
And they've done a lot of that in their development of their tools, so it might be interesting. Okay, thanks so much. That was just fantastic.
Thanks, Janet. So we have a question from Gary. Gary, did you want to unmute and ask, or would you like me to do that for you?
Hi, Ivy. I guess I can unmute.
Okay.
Easier than trying to read my writing, even if it's typing. So anyways, terrific presentation. And I really appreciate it. I was just looking at the issue of mobility, both the patient and the physician, or primary care mobility. So the first one is, if you're anticipating 10,000 people moving into a region, are you able to measure, through ICS or whatever, whether these people already have a primary care provider that they would likely stay attached to when they move into a region? And
just letting people know that Gary is from the Canadian Medical Protection Association, the CMPA. Carolyn, would you like to go ahead? You're on mute, or Sarah?
Yeah. Sure. So currently, unfortunately, our population, unfortunately, so we've been graced with some data from the City of Toronto about urban development, so specifically about new builds and what the growth is expected based on that new build pipeline. So essentially, what we're having to do is the baseline scenario is looking at the estimated number of incoming new residents into each of those neighborhoods. And so the baseline scenario would be that we assume that those people that are coming in have a very similar profile to who currently lives within that neighborhood. We can then adjust for certain kind of population characteristics, as Sarah demonstrated in the scenario dashboards, where you can say, okay, it's a bit of an older population or a younger population or a more diverse population, to start to see what kind of impacts that might have on the needs within that neighborhood. But unfortunately, we don't have data on the exact person who's coming into that neighborhood, and therefore wouldn't be able to do that kind of primary care attachment scenario.
So if I could just, build on that, if that's okay. So the other thing attached to that, obviously, if it's new immigrants coming into the country, they wouldn't be attached versus people who may have come from outside Toronto. So I think that would be potentially important if you're looking at mobility. The second thing that came to my mind, and I don't know how you'd model this, is with retirements, you're having people who've been in some of these inner city communities for many years, And when they retire, the people you want to replace them are unlikely to want to pay those rents or mortgages to open up practices in those communities. So it would appear to me, and maybe this is part of your planning, you need an alternative way to set up the practices so it's actually affordable for the practitioners to move into these areas. So just throwing that out.
Thank you so much, Gary. And so I think what I'm going to do is I'm going to take John's question and John's question, and then we'll have sort of the responses to those two questions. So John, please go ahead.
Yeah, thanks. Kudos to the whole team there. It's a very impressive, large project with a lot of work obviously behind the background on that. So well done. I'm curious if you've run sensitivity analyses on your models, and if so, what has turned out to be the sort of the more sensitive variables, like what drives your gaps in your model?
Okay, and we'll take the next question as well. Go ahead.
Hello, everyone. Excellent presentation. This is Xun Wang from Central Region. So I have a technical question. Actually, it's kind of related to Gary's question. I think a part of the question has been answered, but I'm curious to know, there are a few dashboards has used the neighborhood level population estimates by years. I'm wondering, those population at neighborhood level, as we know, we're able to get easily to get the neighborhood level based on census, but you do have every year. It's very impressive. And how do you calculate those numbers? Did you use like 2011 census, 2016 census? Are you planning to move to 2021 census when you continue the project? And then how did you estimate the population growth, at the neighborhood level?
Excellent, thank you. So I'll pass it over to the team who would like to address which question first.
I'll let Sarah take these ones.
Okay, thanks, Carolyn. What I'll do is maybe start with the question about the origin of population data. So we use 2016 census, and the plan is to update that information with 2021 census information when it's available. And then the information about population growth came from the City of Toronto. So they look at the development pipeline, and they say that within a 10 or 15-year horizon, most things that are in the pipeline end up being developed. And so we used both of those, a 10-year horizon scenario and a 15-year horizon scenario. And we assumed linear growth between the baseline year and the horizon. And we imputed population growth numbers yearly that way, recognizing that development and growth is actually a little bit more lumpy than linear. We know that that's one of the limitations, but we feel like if you take a view that is focused on the horizon, that you can learn things about how growth will impact needs. When it comes to what drives service requirements, what we did is we used the population grouping methodology, and we ran a series of analyses that looked at service requirements as predicted by the pop grouper as an outcome, and various population characteristics at the neighborhood level. and to figure out just what influence each characteristic had on service requirements. And we found that obviously the actual number of patients is a very big influence. We found that the number of mental health and addiction related visits are a big driver of primary care visits, as well as aging and visible minority status. And so when we assembled our scenarios, we chose to use those 3 factors as things that could be explored as variability in population characteristics that could be explored in terms of their relationship to service requirements. Hopefully that answers your question. We're happy to talk about it more if you want more detail.
That's great. Thank you so much, Sarah. And thank you for those questions. I'll just acknowledge that, Kathleen, you did have your hand up if you wanted to post your question in the chat. And there are 2 additional questions in the chat, but just for the sake of timing, I'm going to pass over to Sarah, who's going to be moderating the next part of the presentation, and we will have another opportunity to ask questions. So if you still have some technical questions, please do consider posting them in the chat. So off to you, Sarah.
Wonderful. Thank you so much, Ivy. So the next portion of the webinar is going to be a panel discussion where we are going to talk about the role of this kind of planning within the health system and the contribution that it makes. And so I'm going to introduce our panelists. We have 4 distinguished experts who are going to respond to a series of questions and then to questions from you. First, we have Dr. Ivy Bourgeault, who's a professor in the School of Sociological and Anthropological Studies at the University of Ottawa, and the lead of the Canadian Health Workforce Network. We have Cynthia Damba, who's the manager of health analytics at Ontario Health Toronto. We have Dr. Rick Glazier, who's a scientist at the MAP Center for Urban Health Solutions out of St. Michael's Hospital, a member of the St. Michael's Hospital Academic Family Health Team, an ICES scientist, and a member of the Departments of Family and Community Medicine and the Dalla School of Public Health at the University of Toronto. And our 4th expert is Dr. Curtis Handford, the medical director of the Primary and Community Care Program at St. Michael's Hospital and co-lead of the Downtown East Toronto Family Physician Network. Thank you very much, all of the panelists, for coming together today to talk to us about this project and about the impact that it might have on the primary care landscape in the city of Toronto and beyond. So first, I am going to ask a question directed to Cynthia and to Curtis about why your organizations were interested in engaging in this project and what you see as the most important contribution of this type of health workforce planning exercise to the health system. So we'll go to you first, Cynthia.
Thank you, Sarah. And good afternoon, everyone, again. So our organization, Ontario Health Toronto, requires comprehensive information to make evidence-based decisions around our mandate of planning, coordinating, and funding services in our region. There was a gap in our knowledge and understanding of primary care resources available to meet the needs of the population living in and receiving services in our region. In addition, we have a complex planning environment, as you have heard in the presentations, with great cultural and economic diversity in our population, high population mobility, rapid population growth in some areas, and great diversity of the primary care services as well. We needed a tool that was tailored specifically to address these unique needs for our planning context in Toronto, and to help us proactively plan for current and future needs of our region and understand the changing landscape of primary care delivery. This toolkit is unique in that it allows assessment of team-based care by going beyond just looking at physicians to look at the 13 allied health professionals and really trying to get to team-based care, which is the future of primary care. The iterative and consultative nature of the process ensures that we can continue to refine the process to address emerging needs. And also, another thing is the toolkit can be leveraged and modified for other jurisdictions. So those are why we were really interested in this project.
Wonderful. Our feeling is that the Toronto region has been really forward-looking in terms of recognizing a need and then jumping on doing something about it before getting into a crisis situation. Curtis, do you want to talk about your perspective on why you're interested in this kind of planning?
Yeah, sure. I can add a little bit. I mean, my involvement was initially through a previous role as a primary care lead for one of the Toronto subregions, and I think why I was originally interested is you know, this ongoing very delicate balance between you know, attaching patients to primary care and at the same time enabling access and continuity to a primary care provider, and that sort of delicate balance between all that. And so that's really what drove my personal interest in this project. And I think the contribution is the fact that we really have a you know, a very thoughtful, comprehensive model that really, in essence, is population health in action, and will allow will allow health system planners and health system funders to be able to look into the at least into the short and medium term to be able to determine where the most impactful investments in primary care will be to help improve population health outcomes. So that's a little bit about what interested me at the beginning and what I think the contribution will be from this outcome. So it's great work.
Wonderful. Thanks, Curtis. Ivy, did you have a perspective on this question?
Yeah, absolutely. For me, this was really a dream partnership, you know, for academics to be working with people on the front line. It was an opportunity for us to apply knowledge that we had theoretically, also knowledge and building on, you know, Janet's question internationally, looking at international leading practices. And so it gave us an opportunity to take those and really apply it to a Canadian case. And working with Sarah and Carolyn and their leadership on this, because this is such a critically important issue. So it was really to enable us to, again, apply those two sides of the coin. You need to know what the population health needs are and the health workforce capacity to put that together and see what alignment or misalignment there is in terms of moving forward. So that was an absolute wonderful dream partnership. And so really pleased that it's been so fruitful. Thanks.
Great, thanks. And Rick, do you have a perspective?
Yeah, thanks, Sarah. I mean, it's been a tremendous pleasure for me to see the evolution of this project. A few years ago, when Sarah, you led, and Ivy and others were involved, Carolyn, involved in the generation of a model that would account for need and supply and demand and all of the complexity of all the movement of patients, the new doctors, the retiring doctors, just all of the population dynamics that have to do with supply and demand in healthcare, which are incredibly complex. And I could see all the parts being accounted for in such a beautiful way in the model. It was really impressive, one of the most comprehensive efforts I had ever seen. But then when it came time to say, well, can we actually populate this model? It seemed improbable, frankly. It just seemed like a dream. Like, how could we actually get the data? And of course, the data, as you all know very well, and many of you speak on this topic frequently, the data are very limited and have lots of gaps. But it was actually an unbelievable and very, very impressive effort to populate the data. You've done it in a very sophisticated way. I think it is a promising practice, if not a best practice exercise, and just really, really exciting to see this level of sophistication, detail, comprehensiveness brought to workforce planning in this area. I think we all agree is super important. And the other thing that happens when we start to use data in this way is that the gaps in the data become more visible, and the imperative to close those gaps and to improve the data. You know, our interprofessional team data is extremely weak in primary care. How many full-time equivalents are there? Where are they? Who are they seeing? You know, across community health centers, family health teams, nurse practitioner-led clinics, and so on. You can just think of so many data gaps that occur there. What is the role of pharmacists in the community, psychologists, rehabilitation specialists, et cetera, because primary care is very broad. But it's only through exercises like this that we see where those gaps are, and that the imperative arises to make the data better, because people usually will jump up and down and say, wait a minute, you forgot me. And we say, yes, of course, we forgot you, and let's get better data. So I'm really excited about that opportunity and that cycle of data improvement that hopefully this will help to spur.
Indeed. Wonderful. Do any of the panelists want to have anything to add before we move on to the next question for consideration?
If I can add, Sarah, it's building on what has been spoken before. Like Ivy mentioned, this dream partnership, the same was, it was the same for us from our end. We have strong health analytics, you know, capacity, but we did not have this expertise of, you know, primary care, health workforce planning, which they, you know, the Children Network has. And it's been really great working with the team, and we've learned a lot. We're still learning, and we have got out products which we hope, and we've documented everything, you know, every step of the way, so that we can carry on with it afterwards, but also it can be easily shared with other people. So a big thank you to the Canadian Health Workforce Network, and then also to our partners like the OCHPP team, great staff. Curtis has been there with us from the beginning, you know, offering expertise. So it's been a real great opportunity to work on this. Thank you.
Great, thanks, Cynthia. I think the feeling is mutual. We're so excited to see capacity develop and to see these outputs and to see them making their way into the world, and hopefully having stakeholders start to use them. And that leads into the next question, which is, who do you foresee will be able to make use of this evidence to support decision-making within our current context of health system transformation? And I'm going to leave that one open. I'm not going to pick on anybody. Who would like to tackle that one first?
I can jump in, Sarah. Maybe I'll just
kick
off if that's okay. It's a very tricky question, because historically we have not really done a whole lot of workforce planning, and in primary care especially, we have not. Part of it has been, you know, the large data gaps that have always existed. Part of it has been the lack of sophisticated models like the one that we see now that accounts for so much of the complexity, that is modular, where the modules can all be tweaked and assumptions changed and things varied and it's interactive. But there are a panoply of players who could use the data. And I guess the question maybe we'll get to in the next question is, will they, how will we get this information to them? How will they use it? But it seems to me we have a unique opportunity in Ontario now with the emergence of Ontario health teams, which are meant to be integrative. They're meant to be population-based. They're meant to meet population needs. And so they present a unique and unusual opportunity in the Canadian context for integrated, comprehensive service planning to meet population needs, with all of the local variation, all of the equity issues that happen locally, all the barriers to care, all of the workforce issues that we haven't really understood very well, and all of the dynamics of the graduates and retiring providers and all the interprofessional teams. So it seems to me that Ontario Health, the Toronto region, of course, of Ontario Health, but I think all of Ontario Health could really use this information. The Ontario Ministry of Health around policies like managed entry, where only certain physicians in underserviced areas, in case not everybody understands that term, only physicians who are family physicians who are largely trained in a capitated alternate payment environment. Many, almost all in Ontario, are trained in interprofessional teams, and then very few can actually practice in those models in which they're trained. So directing those physicians who would like to practice in those models to more underserved areas is an important audience and policy initiative. So that's just what the whole sort of managed entry is about. The fact that more than a million Ontarians don't have a primary care home, and about a quarter of those are in Toronto, which is a huge number of people requiring care. So I would think that local communities, need to have a voice here. I would say the emerging and established Ontario health teams, as they come together, could certainly use this. Ministry of Health. I think a lot of these kind of policies at a high level are negotiated between bodies like the Ontario Medical Association and the Ministry of Health. And for these kinds of planning considerations to be brought to that higher level table, recognizing that they have some of the very few levers, because family doctors, after all, are private, self-employed professionals, and nobody can actually tell them, where to go work or who to work with or what model of care to work in. But there are incentives and limitations and incentives on that could be applied as some are, and some could be as to where people practice. So we'll get to this later, but our levers for how to organize the system, and once we have the planning model, how to actually direct care to where it's needed is pretty tricky, and I think actually requires all of the players. And I'm sure I've left out another half a dozen that my colleagues can help to fill in, but these are complex processes, and often primary care is discussed in the context of 100 other issues that the government and medical association are discussing. And sometimes it gets shunted off into subcommittees, and as it did in the last round. And these models of care that could be tweaked and organized and become much more responsive and part of the learning system tend not to get the attention from a workforce reimbursement, team-based kind of approach that they could use. So hopefully that will improve and change over time. But anyway, I'll turn over to my colleagues now, because I'm sure I've left out many others who could use this data for helping us to meet population needs in a much better way.
Thanks, Rick. Curtis?
Yeah, I agree with everything Rick said, and definitely, and I know this is very Ontario specific, but definitely the managed entry program came to mind around increasing the number of family physicians in a capitation based model, and this providing further direction, further guidance for where that managed entry should be focused. initially. The other main category of interested stakeholders that came to mind is our academic institutions, and those who are who are part of the conversation around forecasting the health human workforce need in the coming years. So I just wanted to add that piece.
Ivy.
Yeah, absolutely. And thank you so much. What I want to add, in addition to many of the provincial stakeholders, because this is a provincially focused project, is to bring a sort of a national lens. And in part, what has made this project so powerful is it's an example of here is what is possible. And I'm hoping that there's great interest nationally as well as internationally to take this approach and then figure out, how do you map your existing data? How do you improve upon the data in order to adopt this approach? So everything around health workforce has to be not just adopted, but adapted. And so what is it that we would need to do? And it's very much an iterative process. So, we had this very theoretical model, as Rick mentioned. And then, the part is about the rubber hits the road. Do we actually have the data to populate this model? So the model shifted as we saw what data were available. So some real strengths, the interprofessional focus, absolutely critical. This is the leading practice internationally for health workforce planning. We cannot do this in silos because people don't work in silos. Really innovative approach to unmet need, which is a really complex problem to address. And so that was taken head on. And really, really want to highlight that many stakeholders can utilize this model because we've made it transparent. The dashboards make it accessible, but more importantly, we've published this work. We've published this in peer-reviewed international journals, which we will continue to do so that people can build on it. These are such important principles to highlight of this work.
Great. Thanks, Ivy. And Cynthia, what's your feeling about who will make use of this?
I think most of the groups have been mentioned by the other panelists. What I can add is definitely we're going to be using it as mentioned, earlier. We're going to use this and keep refining it to help inform our planning purposes. Oftentimes, we're asked to identify which are high needs areas. So for the managed entry that Rick talked about earlier, and we go through. We had some methodologies where we put together some indicators and rank them in a simplistic way. So this helps us to actually do comprehensive needs analysis and submit, the high needs areas. We also get requests for funding. Sometimes there's discretionary funding that's available, and they ask us, let's say for primary care, which areas or which regions should be funded. So having all this in a proactive manner will help us be able to answer those questions. The other thing is around city planning locally with the city. Toronto region collaborates with the City of Toronto in terms of identifying some planning priorities that they work on together. And this one around high population growth was one of those areas, because previously what had been seen was sometimes the city would approve all these developments, high-rise buildings and other developments, which bring in a lot of new people, but then would not think about the healthcare implications and resources needed to support those growing population. So in this case, this information can be used for us, for the region to plan collaboratively with the city, so that when they're approving buildings, they take into account the health impacts, and they may, plan for allocating primary care facilities, or maybe putting some facilities in some of the high-rise areas, so new clinics and stuff that can be actually help to serve the population, rather than letting people go to the emerge as their primary care practice. So those are the things I wanted to add.
Fantastic. Ivy?
I just want to build on that. I think this is what has been such a great case study to work on, is to kind of think about how there are so many different stakeholders that can be involved, and really having the City of Toronto consider health workforce and where the health workforce is located when development is being approved, so that we're not just talking about parks and schools and grocery stores. We're talking about primary care clinics. This is so critically important. So this is so innovative and so needed. And I just really wanted to underscore that, that element that Cynthia mentioned.
Definitely, very, very important.
Yeah, and as has been said earlier, we feel like this methodology, although tailored specifically for the Toronto region, it can be used and adopted for other regions, and we can all have a standardized methodology at looking for, at primary care planning. So we'll reach out to, the other regions in the province and try to spread this information.
Yeah, so that leads into my next question about the barriers and facilitators to scale and spread of this type of exercise.
So maybe I'll start and just mention one of the significant enablers for this type of work in Ontario has been the investment in a standardized interprofessional health professions database, the HPDB. And that was purpose-built in, I believe, 2008 for planning purposes. So that has been a huge enabler. And because that's province-wide, this approach and the modules and the tools that have been developed are easily scalable to the province, because there has been that investment made in a standardized health professions database. The health professions database has gaps. We don't know anything about the racial identity of health workers, Indigenous identity, disability, other what we would recognize as important employment equity demographic variables. There may be some other variables that we would want to augment. But I have to say that that was a huge enabler. It was challenging, 27 months of challenging to get access to it for planning purposes. So accessibility is really important, but we are hoping that because of the case that we've made and the output that has come from it, that other jurisdictions are not going to have to wait that amount of time for the HPDB. To talk about scaling it nationally is more challenging, but that is where our eyes are set. And I really want to acknowledge funding that we have received from the Canadian Institutes of Health Research to undertake a project to envision what minimum data standard would be, so that we could create a pan-Canadian or sets of pan-Canadian data sets that articulate with each other, so that we can not just look at interprofessional primary care workforce planning, but mental health and substance use health, long-term care, older adult care, etc. And there were some comments in the chat about how we would articulate with home and community care and long-term care. This is very, very important. And so we will be working in earnest on that project next year in partnership with the Canadian Institute of Health Information to create a much more inclusive and an enhanced minimum data standard, purpose-built for planning and this type of planning. And so in the same way that our theoretical model was modified through the iterative process of going back and forth and knowing what data are and are not available, the same thing will happen with this minimum data standard project. Because as Rick mentioned, you know, once we do this type of modeling, it's much clearer where the gaps in the data are and how incredibly important it is to start meeting those data gaps so that we have continuous quality improvement. And we're very pleased that CIHI has committed to a 3-year cycle of improving their minimum data standards so that the data that they are collecting on the health workforce will be updated. But this is not just a CIHI activity. All stakeholders can buy into, align with a minimum data standard, including the educational stakeholders that Curtis had mentioned, so that we really understand the whole pathway from training, early, mid, and late career of folks and all of the different stakeholder organizations that represent those interests along the way. So those would be a couple of things that I would say.
Great, that's excellent, Ivy. What an exciting vision for the future. In the meantime, other barriers and facilitators?
Maybe I'll jump into, I'm looking at Gary Garber's comment about political will. It's impossible to ignore that issue. We do know that the election platform for the federal government did include a commitment to 750 family doctors and nurses, mainly around the primary care attachment gaps across the whole country. We don't know yet if the ministerial mandate letters, budget 2021, all those kinds of things will align around primary care need. We've certainly seen it recur over the last few years. And it certainly was front and center in the election, as a commitment. So that would be, if there is funding coming to provinces and territories for them to make decisions about workforce and gaps, this kind of information, these kinds of models are incredibly important to make thoughtful, forward-thinking, near to medium-term decisions about where should these new kinds of primary care resources be deployed. The other thing, I guess, that could be a facilitator. If there's federal, provincial, territorial alignment around new funding, new resources, new health professionals around primary care gaps, particularly if they're supported with digital infrastructure, virtual care, and other elements that would expand access, that would be a really great facilitator. In terms of barriers, no one's in charge of primary care. Nobody's in charge of workforce planning. Nobody's in charge of primary care workforce planning. So we don't have a centralized body that does that. And yet we can see the crisis unfolding in front of us in nursing. We can see the enormous levels of physician burnout. We can see what's happened with personal support workers in long-term care and home care. We can see that we're in the middle, actually, not on the verge, but in the middle of an absolute workforce crisis across the entire system, with primary care kind of as the front door to that system, if you like. So there are tremendous opportunities to pull together federal, provincial, territorial initiative around workforce that would actually have models like this as a core tool and a key way to make decisions about where resources should go, what resources are needed, how they should all be pulled together. Because there is no one in charge, it's really crying out for some kind of both provincial and national, pan-Canadian type approaches to improving the data and iteratively doing the planning and deploying the resources that are needed. And again, I think this has become through the pandemic such an imperative that I think the opportunity cost of not directing resources and not doing the planning appropriately, the opportunity cost is enormous in terms of our health system and the consequences for our health system.
Indeed. Thanks, Rick. Curtis, do you have a perspective on barriers and facilitators?
You know, I don't have too much more to add, but I would say, you know, one of the facilitators could be the, you know, the healthcare professionals themselves. I mean, you know, the vast majority of whom, you know, go into their profession of choice in order to, you know, in order to improve health outcomes in a population. They may not know it as that when they go into it, but, you know, but that's ultimately what they're wanting to accomplish. And, you know, I think that this could be very, you know, if it's distilled down into its most understandable terms, so that non-experts can really grasp what data like this is intended to accomplish, I can really see that the healthcare workforce itself really getting behind this and actually asking for it in you know, making decisions about where they want to work, where they feel they're most skilled, and where they think they can have the biggest impact in improving population health outcomes. So that came to mind as we were chatting here.
Excellent. And Cynthia, I'll give you an opportunity to comment, and then we'll use the remaining time for questions.
Yeah, most of the barriers and facilitators have been mentioned by the other panelists. Really, what we saw as the biggest barrier here was the data, and that has been talked about multiple times. It really having access to timely data would be very helpful. And also the fact that currently data is available from many different sources. It's produced by many different groups. It would be good to have data automated, you know, and having the technology to pull together this data in a quick, timely manner so that we can use it for planning. Oftentimes we rely on a big data when we know things change rapidly. The population changes, the physicians and the primary care workforce changes. So improving on the data can't be emphasized enough. The other is another challenge which has been made more evident is the changing landscape, primary care landscape. So just this past two years, COVID pandemic came along and changed everything, which we had been planning for. When we started this exercise, we were planning for mainly in-person, trying to get people closer to home. And then along came COVID and increased use of virtual care, increased use of pharmacies, as you heard earlier, physicians retiring you know, early due to burnout and stuff. And we don't know whether these changes will revert back to the original practices or they'll remain in the future. So it's really important to have a tool that can sort of anticipate or at least help to factor in, you know, the changing landscape and population. So that's why it was important to have a tool like this. Maybe in terms of facilitators, I think Ivy had said previously, you know, making this transparent with publications, having the open access data to OCHPP, on OCHPP. There's also a RISE brief, and I don't know if Ivy or Sarah can talk about it, which is being prepared for Ontario health teams to better understand, you know, planning using this sort of tool, We are also engaging different Ontario Health tools. Actually, right now we started work with the North York General Ontario Health team to actually now take this beyond just having the data, but actually put it in real life practice. So we'll work with different groups like that to look at, you know, what evidence is coming out, what needs and gaps are coming out, and we'll keep refining. And in terms of facilitators, I can't emphasize enough having partnerships, the partnerships we've talked about here, the expertise for different groups, you know, frontline, you know, everybody, those are, I think, critical for such a process. Thanks, Sarah.
Excellent, thanks, Cynthia. Very comprehensive look. Between everybody, we have a whole collection of barriers and facilitators. There were a number of questions in the chat. We don't have enough time to cover all of them. There is a question about virtual care and whether that's a barrier or a facilitator, and one about national licensure. And I will leave it open to the panelists to pick one and comment.
So I'm going to pick the easy one, and I'm going to let others do virtual care, but as if national licensure is easy. But we have been having a conversation about national registration, which does not require us to regulate nationally or at a pan-Canadian level, but that there would be coordinated registration. And that would be one place where we could adopt a minimum data standard so that we could have what is essentially an Ontario Health Professions database across Canada. So national registration enables the provinces and territories to keep regulations, so they would still do discipline, complaints, etc., but that there would be a national registration process. And some professions have moved in that direction already. Physiotherapy, midwifery is almost there. And so that would be what I would suggest as a huge enabler. It doesn't require the regulation to be at a pan-Canadian level, but registration at least. And from a modular perspective, we could include data that is necessary for the regulatory authorities around patient safety, discipline complaints, so that you don't have people moving around who, you know, have some issues with their license. So that would definitely be a facilitator. I'll pass along about virtual care.
Who wants to tackle virtual care? Barrier or facilitator?
Rick, go ahead.
No, I'm waiting for you, Curtis. Please go ahead.
I mean, to be honest, I think I'd be guessing. You know, my gut reaction on this is it's too early to know. You know, as everybody on the call knows, you know, we're really building the virtual care plane as we're flying it, and my sense is that there's going to be a sweet spot for virtual care in our system. But it's probably going to take not quite a while, but it's going to take some time of sort of diligent science to try to figure out, and observation to try to figure out what that sweet spot is. So it's maybe a cop-out, but I think it's too early to know.
Yeah, I agree with you, Curtis, that I don't think we've settled on appropriateness, timeliness, appropriateness, access. My own experience, and maybe yours too, Curtis, and others on this call, is that virtual care doesn't necessarily save time. That a phone call visit or a video visit can sometimes take just as long as an in-person visit. And that was a surprise, because you'd think that things could be handled more expeditiously on the phone, but you still want to do a comprehensive job. You still need sometimes to make referrals or order tests or follow up. So not all virtual visits are shorter or simpler than the actual ones, especially in the early days when we were handling just about everything virtually and had less ability to kind of triage only the people who really needed an in-person visit. It does help in many ways, though, in terms of the geographic kinds of issues we've been talking about mainly today, that, you know, virtual provider, if you live in the north, could be anywhere, and, you know, you're not constrained to the neighborhood that you live in, or even the region of the city or the region of the province that you live in order to access virtual care. So that the workforce maldistribution that we have across the city of Toronto and across the province of Ontario maybe could be addressed through some aspects of virtual care. Of course, the danger or the downside or the reason, the answer is yes. I think that it's both a barrier and a facilitator, is that, you know, the discontinuity, the challenge to appropriateness in terms of settling out what's appropriate, what's not, the corporatization of virtual care, duplication of services. You know, I have a patient who's young, who had very minor problems, had 2 in-person visits with me, 2 virtual visits, and 6 video visits with a private company providing video visits, resulting in numerous referrals and tests, none of which were actually indicated. So, but were insisted upon and demanded by the patient to the point where the provider was, I did get notes back on some of these. So, you know, just so I would say, as Curtis has said, it's not settled out yet. The promise is there, but in actuality, how virtual care will contribute to timely and appropriate access to care, I think is being worked out. Gary, you might have other thoughts.
We could probably talk about virtual care and other barriers and facilitators all afternoon. Do you want to take 30 seconds, Gary, and respond?
Rick, I think it's a double-edged sword, and I agree with you. I think there's great potential for facilitation if it works. I think it also, if it's overused, I think it becomes more of a burden. And I think we have to figure out where virtual care fits into the appropriate level of care and distributing, you know, the right work at the right level. And I think we haven't figured that out with virtual care yet.
That sounds about right. Now we're getting ready to wrap up, and I'm going to pass it back to Ivy for a few final words. Before I do that, I'd just like to extend a big thank you to all of our panelists for joining us today and for the time they've taken to think about our questions and share their expertise. Thank you.
Absolutely.
Ivy.
So if I could echo that as well, it has been absolutely wonderful working with partners. And now at Ontario Health Toronto Region, I still have to get my mind around that. Cynthia, Ting, and Nathalie, thank you so much. Anne Marie at the OCHPP, that's been a really, really superb partnership. And Curtis and Rick, thank you so much for coming on to speak to the importance of the issues that we're looking at. So, and I in particular want to thank Carolyn and Sarah for being the brain power behind this. It's been an amazing, amazing academic and applied partnership. So thank you so much, both of you, for sticking with it, because we didn't know what we were agreeing to in 2017 and that it would be quite so long, and also that we would be in the middle of a pandemic for it. So this is really a demonstration project. We want to move forward on this. This is not a pilot project that we want to die. We want to build on this. And so we really want to hear from you. I'm going to end on a political note. If you haven't considered signing on to our call to action for there to be better health workforce planning and federal leadership in that regard, it's in the chat. Our call to action, we have over 60 organizations that have signed on, and we just earlier today became a member of HEAL, the Canadian Health Workforce Network, and are really hoping to move quickly and to build on this work and to bring it to scale, not just across Ontario, but across Canada. So please join us in that. Thank you, everybody, again. Have a wonderful afternoon.
Thank you.